Good afternoon and welcome to the International Myeloma Working Group Conference Series, Making Sense of Treatment, moderated by Dr. Brian Durie. Next slide, please. A huge thank you to our sponsors, Johnson & Johnson and Karyopharm Therapeutics. Next slide. Just a reminder that a replay of the webinar will be made available on our website early next week. You can find it under the Publications and Videos tab on our website, and also a replay link will be directly emailed to all who registered for this webinar. Next slide. At the close of the meeting, a feedback survey will pop up on your screen. Please click Continue to complete the survey or utilize the email to do so that will be sent to you after the webinar. Your responses to this survey mean a lot to us, and we use them to improve webinars and programs in the future.
Well, thank you so much, Becky. We're going to go ahead and get started. We've actually had some trouble connecting Tom into the conference series here. However, as soon as he connects, we will bring him in for the discussion. But I'm very grateful to have joining me right now Dr. María-Victoria Mateos from Salamanca in Spain. So welcome, María-V. Really appreciate your willingness to participate today and give us your words of wisdom. The topics that we're going to cover today are those that have been in discussion related to, excellent. So Dr. Martin, welcome. We have just, so pleased that you can join us also from Spain. Is this true? Yes. All right. So we have two participants that are in Spain. So the topics we're going to cover are ones where there were updated abstracts presented at ASCO in Chicago or at the EHA meeting in Madrid, or some related recent discussions. And so we're going to cover these items I've listed here, from early disease, MGUS and smoldering myeloma, updates from Iceland, frontline therapy, some different aspects related to MRD testing, minimal residual disease, Belantamab, the DREAM7 and DREAM8 trials, a lot of excitement about the readout of those trials from both ASCO and EHA, some CAR-T updates by specifics, and then some assessment of where are we with venetoclax. So next slide. All right. There we go. All right, so starting with early disease, one thing that was discussed a lot actually at our IMWG Summit was risk stratification for HRSM, which is high-risk smoldering multiple myeloma. Obviously, a 50% risk of progression at 2 years is a reasonable definition, depending upon what one might be choosing to do at that point. However, with any kind of significant intervention, we would like to have a higher risk of progression, more like 80%, and multiple risk assessment models have been developed. The 2020, which is one we've used for these last few years, involving the level of the spike, percentage plasma cells in the bone marrow at 20, and the free light ratio at 20. Then we have the Spanish model, the IMW risk score, which includes some FISH genetic testing, and then something new that was discussed in Madrid, which is a dynamic model. And if we have that next slide. Yes, so Dr. Shaji Kumar presented a dynamic model of progression where he looked at 3 factors which changed over 6 months, including the level of the myeloma's protein spike in the serum, the free light level, and the hemoglobin level, with a decrease in the hemoglobin level, a progression towards anemia. And using these 3 risk factors, it was possible to develop a score model where none were present, 1, 2, or 3 were present. And obviously you can see if you look at number 3, there was a significantly more rapid progression towards active myeloma if all 3 were present, but equally a trend for 2 risk factors. And so perhaps first I can ask Mary V, what did you think of this dynamic modeling, and can this really assist us in being more secure about high-risk smoldering progression?
Thank you very much, Brian. And I think that this dynamic score will help a lot us as hematologists in order to identify with much more accuracy the population with the smoldering at high risk of progression to myeloma. And sometimes some hematologists, when they do the diagnosis of smoldering myeloma, sometimes it is difficult to accurate if the patient is at low risk, intermediate risk, and especially high risk, because the identification of high risk patients can potentially change the practice, because maybe the patients can receive treatment, or the patients can receive or can be included in a clinical trial. So the possibility of being evaluated, the M spike, the free light chain, as well as the hemoglobin over time. And I think that in 6 months' time, it is a reasonable time, even from the patient perspective. I think that it is very helpful because, again, will help us to optimize the identification of the population with high risk. And as you said, the group 2 and the group 3, well, are definitely patients at high risk, but we can see how, as you pointed out, the group number 3 clearly will identify patients with a truly high risk of progression to multiple myeloma, in which maybe the need for an early intervention is much more necessary. Although, of course, if we have a clinical trial, I will consider that this is going to be the best option for the patients.
Yeah, absolutely, absolutely. So Dr. Martin, Tom, I assume you probably agree that this can be a helpful model. Obviously, these are tests which are readily available, so it doesn't entail any extra special testing.
Yeah, I completely agree with María-V, and I think we will all feel more comfortable having this dynamic model, because we don't want to overtreat patients that we think won't need any therapy, at least for some time. So this would, I think, really help in terms of selecting the people that we think truly have high risk smoldering myeloma and need treatment.
Right, absolutely. Okay, so let's continue on. There were several updates from Iceland presented at ASCO and EHA, and I'm going to go through what were 4 updates. And so this first update was presented as a poster and was quite intriguing. And this relates to the presence of obesity in individuals with MGUS identified in this population-based screening study from Iceland, in which over 85,000 individuals were screened from Iceland. And the dots which are moving down and over to the right indicate that as there were higher levels of being overweight, obesity, then the risk of having MGUS increased. And so there was a very strong correlation with increasing obesity and a higher likelihood of the MGUS diagnosis. And so this is really quite an interesting and important observation. Next slide. Oh, okay, I think I got it. Another observation is looking at a population-based screening versus MGUS diagnosed clinically. And if you look at the bottom part of the slide, MGUS diagnosed clinically, it has a blue dot, which is over to the right. And so that is correlated with autoimmune disease, whereas MGUS diagnosed by screening has a big blue box at the top, which is not correlated with autoimmune disease. And so there's quite a difference between whether MGUS is coming from a screening where there's no necessary underlying disease versus where a patient has come in to the clinic or the hospital. Another study is the use of a model to tell if patients with MGUS need to have a bone marrow sampling or not. And I think that this is particularly helpful and important. And there's a simple algorithm where you take the levels and the types of the protein and log it in to the system, and you can determine if the percentage of plasma cells in the bone marrow is likely to be beyond the MGUS level, beyond that 10% level, where it's important to get that bone marrow test done. And I think that for all patients being monitored, this is very, very helpful to limit the bone marrow to the patients who really need it. Yeah, so you can predicted risk of having greater than more 10% plasma cells is 11.8%. And so this is information where the doctor can decide with the patient that shared decision-making. If it's 11.8%, you could decide you want to wait. Or if it's higher, you might decide that, you want to go ahead and do the bone marrow. Okay. And I think that one other thing, which I think was particularly important coming out of the iStop follow-up, was the fact that patients who develop myeloma after having been closely followed with screening are much less likely to present with any CRAB criteria. And so the purple is much less than the gray in both instances of any CRAB or certainly an acute presentation. And so it really makes an important change in the way that myeloma patients are presenting. And this has been described as changing the face of myeloma, where they're much less likely to have CRAB if there has been a screening. And so if we highlight these four findings, perhaps you guys can react. I think that all of these are important and interesting. How would you react to these first, Tom? Interesting, important, all of them, some of them?
Yeah, I think they are very important, actually, especially the one for prediction of need of a bone marrow biopsy, so that we don't have to bone marrow everybody that has MGUS. We use that, actually. It's great that you just go right online and you can use the metric that they put together, and if they are in the bar that you need to do a bone marrow biopsy, we go ahead and do it, which is great. I think in terms of just screening outright for people with MGUS right now, I don't think we're ready to cross that line just yet, but we're really interested in following up with this study and seeing how that goes.
Exactly. María-V, you're...
Yeah, I completely agree. And when you were presenting the data, I was thinking on Sigmundur Kristinsson that he always concludes his presentation, is it time for screening? And right. He usually says, not yet. But I think right. that we are closer and closer. Why? Well, the obesity findings are extremely important because this is something that we can modify. The MGUS not linked to autoimmunity. It is important because all rheumatologists do usually order M protein and serum protein electrophoresis. But I agree with Tom to try to individualize the need for bone marrow. MGUS is very frequent, and indeed, a junior hematologist in our department is validating this project in our series.
Wonderful.
And finally, the possibility of changing the face of myeloma is important for the patients because we've seen how in the control arm, in the group of patients in which they were followed, the progression to myeloma occurred with less lytic lesions, with less renal impairment. So clinical features that clearly impacting the quality of life of the patient. So extremely important. And again, we are closer to plan screening for MGUS.
Yes, exactly. Thank you. Yes, obviously I fully agree with your comments. And so a lot of focus at ASCO, EHA, and generally at the IMWG Summit about frontline therapy, particularly the use of 4 agents, particularly an anti-CD38 agent, monoclonal antibody. In this case here, I'm showing you data for 2 trials involving the anti-CD38 isatuximab with Velcade, Revlimid, and Dex. In one case, the IMROS trial versus VRD, and in the other, the benefit trial versus ISA-RD, which is obviously very similar to the DARA-RD, the Maya regimen, which has become the very popular standard of care in the non-transplant eligible population. And so these studies presented at ASCO and EHA for the IMROS, the 3-drug versus the 4-drug. Obviously, you can see at the top, the purple showing higher response and higher levels of MRD negative. And then down below, you can see an improvement in the length of the remission, the PFS, in this case of the 4-drug isatuximab VRD versus VRD. Over on the right, you can see significant improvement in the response. However, as of now, we're not seeing follow-up with a PSF benefit. And of course, in this population of the non-transplant eligible, there are more issues related to, well, what are the side effects and toxicity of the ISA-VRD versus a rather effective 3-drug regimen. And so perhaps, Marie-V, you can give me your reaction first. What did you think about these 2 trials? A lot of hype and discussion about both of them around these meetings.
Yes, so I think that both are complementary studies, and I think relevant studies that can potentially change the standard of care for the newly diagnosed myeloma patient transplant ineligible. I would say that the winner is the anti-CD38 monoclonal antibody plus lenalidomide and dexamethasone, because I think that this has to take part of the standard of care. And the key question is if we add bortezomib and we convert the 3-drug-based combination in the quadruplet, well, we are going to definitely to increase in both studies the MRD negativity rate. And it is quite comparable in both benefit and IMROD. And the MRD negativity rate is closer to 60%. It's
Right.
true that we see a significant benefit in the IMROD because the control arm does not include the anti-CD38, and not yet in the benefit. The control arm does include the anti-CD38 monoclonal antibodies, but it's true that the follow-up is shorter. So maybe for me, there is not any doubt that we are moving towards the use of the quadruplet combination. But the key question is for which patients? For all transplant ineligible myeloma patients, maybe the answer is no. Maybe we have to define very well which patients will be eligible for the quadruplet, and maybe fit the patients with a lot of comorbidities, with a good performance status that can tolerate the quadruplet combination. And I think that this data, especially in road registration study, I think that are great. And I think Tom is one of the authors of this manuscript published in New England Journal of Medicine. And this means for the patients that this will be a new standard of care.
Absolutely, Tom. Yeah, so Dr. Martin is a part of these studies. And as Marie-V mentioned, this was a special situation where both were simultaneously published in the New England Journal, which was actually amazing coordination and timing. So Tom, comments from you?
No, I agree. This, this meeting was very exciting for CD38s together with VRD, the quadruplet therapy for patients with newly diagnosed myeloma. I actually was surprised by the benefit study. I was anticipating that ISA-RD would be very similar to ESA VRD, that there wouldn't be so much benefit. But as María-V said, the number of patients that hit MRD negativity was quite a bit higher with the quad versus the triplet. And in EMROS, the biggest signal in my mind was pneumonia. There was 20% grade 3 or more pneumonia in the quadruplet arm versus I think 13% or so in the other arm. And that's not really much of a difference. I think it is a very tolerable regimen. And with EMROS, it went up to age 80. I think for sure patients up to age 80 can tolerate this quadruplet and should be our standard of care. And the projected PFS for this study is upwards of 90 months.
I know,
That's
it's incredible.
really amazing for a non-transplant regimen.
Absolutely. Thank you for that. Yeah. And so I have one other item related to this, which is sort of an extension of the discussion, which was that in addition to these data, we also had an update of the Perseus trial where Peter Sonneveld was looking at MRD negativity all the way out to 36 months. And the question is, how much more information did this give us for, in this case, a quadruplet with Dara versus isatuximab? I think for me, it just reinforced that there is some evidence of sustained benefit with both PFS benefit and MRD benefit. Tom, what did you glean from this Perseus update?
I think what you said is entirely correct in that the MRD negativity rate is really high. In the arm that got Dara VRD, those people that were MRD negative at 24 months actually stopped the CD38 antibody, and so it'll be really nice to see the follow-up from that. Can we actually use MRD negativity to stop some therapy? So I'm very excited to see even the next presentation of this study.
Yeah, just to see that longer follow-up. Yeah, so it's a little bit, we're not so clear what will be the longer term outcome. So María-V, your thoughts?
Well, I think that the data are impressive. From my point of view, what I like much more is the progression-free survival curve that it was presented at ASCO 2023, but the PFS curve is excellent. From the minimal residual disease point of view, well, for me, we have to clarify that what they presented was the cumulative minimal residual disease negativity rates.
Yeah.
So this is something that we don't usually see, because we usually see minimal residual disease negativity rate at a specific time point and sustained over time. This can result maybe in a bit overestimation of the MRD negativity rate reported in the trial. But anyway, for me, I think that the data are excellent because a significant proportion of patients achieved MRD negative, but especially sustain it over time. And it was great to see the progression-free survival based on the minimal residual disease status, putting in context that MRD does continue being maybe the most powerful prognostic marker. And the progression-free survival curve for those patients in minimal residual disease negative is excellent, because basically over 90% of the patients remain alive and progression-free. And I think that this is great.
Yeah, I think that benefit, PFS and survival correlation is very good. So actually, what I'm going to do is just touch upon, and you can comment on this, and the ODAC meeting where actually MRD ended up being approved as an early endpoint in clinical trials. And Tom was actually a participant in this meeting, so we'll appreciate particularly his thoughts about this in the use of MRD. And so this is the team, the I-squared team, that had been working on this project for about 10 years to see if regulators would actually approve MRD as an endpoint that would be sufficient to support anticipated PFS and or overall survival benefit. And so it was great. We were able to have trials from several academic sites as well as trials from our industry partners, sufficient to submit along with studies that were presented by Ola Landgren and the evidence team to the FDA, which led up to this very favorable vote by ODAC indicating that they did support the use of MRD testing within clinical trials as an early endpoint, and as I'll show you, with a 9 or a 12-month testing time point. And so, Tom, maybe the first thing you can do is comment about the tension in the room when we were awaiting that vote. It had been a very long day, and then in the middle of the afternoon, after all the data had been presented, there was a period of silence as we waited for this vote to occur.
Yeah, it's interesting actually at the ODAC meeting. There was a lot of tension, and everybody was waiting for the flash of this screen to see. But beforehand, the I² team and yourself, you guys did an amazing job presenting the data, and it was very statistically sound. And the FDA's statistician, commented that the patient level data had really shown that MRD negativity does correlate to improved survival in patients with multiple myeloma. And so I think we all knew what this vote was going to be, but we just had to wait for that final second. And I will give you an example of that is that there was also an update at EHA from the GMG-HD7 study from Mark Robb from Germany. And that was a randomized ESA VRD versus VRD study that we heard the MRD results 3 years ago, and this is 3 years later.
Wow.
And the regiment's still not approved because at that point they wouldn't approve an MRD endpoint. So this is going to allow studies like that to be approved literally 3 years earlier. So that's what it amounts to. It's really an important endpoint for us.
Yeah, absolutely. Just let me just go forward here. Yeah, so the specific thing is in the blue, dark blue at the bottom of this slide is basically what was the voting question for the ODAC committee, that MRD negative combined with CR, which Marie-V, you were commenting on earlier. I mean, I think that composite endpoint, MRD negative and CR, with at least a 10 to the minus 5 threshold, and at a 9 or 12 months is reasonably likely to predict clinical benefit. But for each clinical situation, transplant eligible, transplant ineligible, and relapse refractory. So I think it was really quite fortunate. As you can see here, MRD negative patients with PFS benefit significantly superior in each category. And so I think that we are now quite fortunate, as Tom was indicating, that we can have this early endpoint in these trials to move our studies forward more rapidly. So your reaction, Marie-V, to all of this?
No, my reaction is excellent. And I think that in this slide, again, we can confirm the role of the minimal residual disease negativity. From my point of view, what we have to do is to harmonize the evaluation of the MRD according to what FDA is saying. And you see here, 9 months, MRD negative, CR status 10 to the minus 5. And we can explore 10 to the minus 6 because maybe it is better. And this is what we have to report in all trials. Otherwise, if every group will report a different time point and a different MRD negativity rate, we are going to confound to the audience. We are going to confound to the patients because they can see 80% in a trial, in other 30%. And I think that for me, this is what we have to do after this FDA commitment and FDA resolution, that I think that it is extremely positive.
Right, absolutely. I think that having a standardized template, very, very important. And then to be aware that these are minimal criteria, at least that 10 to the minus 5 threshold. In a particular study, one could prefer 10 to the minus 6. And obviously there was a lot of discussion about, as often as possible, sustained MRD negative with a 6-month and a 12-month follow-up. So I think that this really does raise the bar for trials moving forward and standardizes them and allows them to be better compared, as you mentioned. So I have to say that the reaction was very, very enthusiastic and positive related to all of that. Now, another way to use MRD information is as a basis for stopping treatment, stopping maintenance. And so there was a bit of interest about this study from the University of Chicago, MRD to Stop trial, presented at ASCO, where 47 out of 83 patients were able to discontinue maintenance and were followed, and MRD negative at 10 to the minus 7 in this case was associated with a 3-year PFS at 85%. And so I think this did indicate that in the setting of sustained MRD negativity can become a reasonable basis for stopping therapy, which would be great. Who would like to comment on this first? Tom, or do you want to comment?
Sure. You know, Ben Derman
Yes.
and Andres have done a really good job looking at MRD in clinical trials at University of Chicago, and they've done this, you know, for quite some time. I am not surprised by these data. I do think that MRD negativity, especially sustained MRD negativity, and like María-V said, we need to have a solid definition. Is it going to be 12 months? Is it going to be 24 months? But we have to have a definition like that so that we all can try to do trials where we stop therapy after a certain amount of time of MRD negativity and then follow patients to show that, you know, their quality of life is best when they're off therapy and that they can maintain being off therapy once they achieve this very, you know, good response.
Absolutely. María-V, thoughts about this?
The same, and just I would add that once we have confirmed the role of minimal residual disease negativity as something based on what we can stop maintenance, when you see the progression-free survival curves in those patients in which the measurable residual disease is positive, we needed to implement something in these patients in order to try to convert them into negative, because definitely maintenance with lenalidomide or len plus bortezomib, that it was the standard of care in this trial, is not enough. Of course, this is the next step, but I think that this is something that also we can learn.
Absolutely, yeah, I fully agree, yes. This is a beginning. Okay, so now we can dream big again. We have Dream 7 and 8. So there was a lot of discussion about dreaming at ASCO and EHA. And so we had the Dream 7 trial at ASCO. And so obviously, María-V, you know this very well. And I'll have you comment, obviously. But I think that Belantamab mafodotin, so anti-BCMA, with a drug conjugate. This is something that had ended up being withdrawn in the US because of failure to meet a follow-up endpoint. But looking at the combination with Velcade and Dex versus daratumumab, Velcade and Dex, really quite an important test. And results really quite promising with, as it says, significantly and clinically meaningful PFS improvement. So very good. I'm going to go through Dream 7 and Dream 8, and then we can comment. So very, very significant in this setting. And then, so for the Dream 8 trial, a very similar type of design where you have the anti-BCMA drug conjugate Belantamab mafodotin, plus in this case, POM-DEX, so a very reasonable and manageable combination actually, versus the POM plus Velcade and DEX. And so again, really a rather significant improvement in PFS, and really and a trend toward overall survival benefit. So I think that with both of these trials, definite indication of benefit. And I think what people were also interested in, a safety profile, a toxicity profile, which is manageable, and with planned timing and dose reductions as necessary to avoid any significant or progressive eye side effects, keratopathy. So what can we say? Let's see if we can. Belantamab, is it back? Is Bella back? So maybe María-V, you can tell us, is Bella back?
Yeah, so I think that you are right, and maybe Bella is back in because, well, I think that we can't use yet Belantamab mafodotin again because it was drawn from the market. But now I think that it is the appropriate time for consider that Bella in combination with VD or PD can be new standard of care in relapsed refractory myeloma after just one prior line of therapy. So we are not talking about heavily pretreated myeloma patients, but just after at least one prior line of therapy. I think that the two clinical studies are quite complementary because both showed a significant benefit in progression-free survival, also in complete remission rate, in minimal residual disease negativity rate, with a trend to benefit in overall survival. But maybe patients would be very interested in something that you comment, Brian, the safety profile, because of the ocular toxicity. And again, this is a learning process. And at the beginning, maybe some patients know that the ophthalmological evaluation was quite strict. And indeed, the ocular evaluation included the evaluation throughout the slit lamp in order to evaluate the potential keratopathy in the epithelium of the cornea, together with the visual acuity. And now we know that sometimes the ophthalmologist reported a lot of microcysts in the corneal. We consider that this was very severe, but when you had the patient in front of you, the patient was able to do their daily living activities because this microcyst didn't impact in their quality of life. So this is the reason why now we are moving towards the evaluation of the visual acuity together with the symptomatology reported by the patient. And we have seen how very few patients do present a severe worsening of the visual acuity, and the majority of the patients can present just a moderate deterioration of the visual acuity. And in addition, and this is also important for the patients, the toxicity is dose dependent and the efficacy is dose dependent. So it is important to give a full dose at the beginning, but it is possible to increase the weeks between two doses later on. And there are some patients receiving Belantamab every 10, every 12 weeks. So just one dose every 3, every 4 months. This is not going to impact in the efficacy, but this is going to impact in the safety profile. So I think that this is the learning message, and hopefully these two new combinations will be available for the patients because of course, this is a BCMA targeted therapy. We are going to have CAR-Ts, we are going to have bispecific monoclonal antibodies, but Belantamab is an off-the-shelf drug, does not require hospitalization, does not require pre-medication, there is not high risk for infection. So I think that there will be patients in which this combination will be the right choice.
Thank you for that wonderful summary and overview. Tom, thoughts? I would assume that you agree with all of that. I think that efficacy and better understanding and ability to manage the side effects and the knowledge that the spacing of the dosing can retain efficacy and reduce toxicity. So Do you expect this to be moving forward?
I definitely do. This was, I think, one of the biggest surprises for me for these meetings. And I did tweet out that I think it's the comeback kid of the meetings.
Okay.
And, we went head to head with JERA really in the three drug combination and won by a long, measure. And then it went head to head with Velcade in the other study and again, won by a long measure. And just the fact that patients have a PFS of generally over 3 years with both of these studies suggests that they were able to tolerate it, like María-V was saying, and able to continue to receive it. And sometimes only 4 doses a year after they have a response, which is very convenient too. I would say the only thing the piece of data that we are missing is that this is a BCMA targeted therapy. So if we put people on this therapy, then what happens downstream when we want to use a CAR T-cell therapy, or if we want to use a bispecific, what is the sequencing going to look like at that point in time? What's going to be responses for those, future therapeutics? That's really where we need more data.
Right, and that's where the immune therapy registry and database are going to be so useful, Tom, as you know. Okay, so another just intriguing follow-up, there are so many data sets with CAR Ts moving forward, but I have been intrigued just to keep track of the fast CAR T, the product coming originally from China and presented by Wandu in the high-risk newly diagnosed setting. And so I think that it's really intriguing to see amazingly good results with this fast CAR product with novel manufacturing where you get young phenotype T cells, possibly more effective T cells. Interesting to see the use of the CAR T after VRD induction, and obviously high overall and MRD response rates. So I guess, Tom, what from your immune therapy perspective, how do you view a new product like this?
It's a really good question. CARs, we definitely have space for more CAR T-cell therapies. We only have 2 that are available now in the US. We do need a 3rd and a 4th in my mind with all the patients that potentially could benefit from this. Here they tried it in newly diagnosed. I think it'll still be a while before we're able to do it in newly diagnosed, but now that they've moved to early relapse, I think a much more broad population is going to need CAR T-cell therapy. I think the big question with this targeted, therapeutic is whether CD19 truly adds to the long-term responses for CAR T-cell therapy. Does it knock down a bigger population of cells that maybe don't have BCMA and may have CD19 instead? And that's really I think where the crux of this is. I'm excited about it. Certainly getting CAR T cells back faster rather than waiting 6 to 8 weeks when patients can progress or might not be eligible to receive it at that point in time. The sooner we can get them out and get them back into patients, the better. So we're going to follow along very closely with this. And as you know, AstraZeneca is now trying to market this in the US.
Exactly. How do you react to this, María-V?
No, I think that it is important. I agree with Tom. I think that more CAR Ts are always welcome. And this CAR T has the main features that it is targeting BCMA, but also CD19. And maybe the patients have to know that BCMA is a marker typical from the plasma cells. And it seems that CD19 is expressing the progenitor myeloma cell. And in addition, because of the process of manufacturing for this CAR T, well, it is going to be very fast. And this means that the availability for this CAR is going to be very rapid in order to arrive to the patient. And in addition, this process is able to select the T lymphocytes with a better quality. So I think that this will impact also in the efficacy. The preliminary data presented at EHA are great because newly diagnosed myeloma patients with high-risk features and the MRD negativity rate was basically 100% with a good safety profile. All patients had received induction with VRD. So I think that this is also important. The tumor burden will be lower and the safety profile is good, and maybe this can impact also in the efficacy. And I agree with Tom, AstraZeneca is planning to develop this CAR-T, and I think that all centers in the US, and we hope that they will bring with this CAR-T also to Europe, and we are pleased to participate, of course.
Yes, that would be wonderful. Yeah, I think that that type of broad access is what we're all looking for. These great therapies, we really want them to be broadly available for sure. Okay, so another trend is to see what is happening in the real world. And so there was interest in the teclistamab abstract at ASCO, looking at the real world data where teclistamab was continued with the starting dose, or was reduced to every 2 weeks or once a month. And basically with the dose reduction, the comparable overall response rate to the MajesTEC-1 was notable. And so I think that this type of de-escalation real-world data set is quite important as we look at modifying these schedules in a way that can be much more manageable in the day-to-day setting. So, Tom, this is an area of particular interest to you. What was your reaction to this study?
So Carlin Tan is actually a member of our immunotherapy database project. And
okay, in fact, great.
Yeah, we're doing the same thing, and it will include all these data with a larger patient population, because we also have 30 or 40 patients, similar patients treated at UCSF. And so we will have something a little bigger for ASH, but certainly in our experience, and what Carlin presented here is that, you can basically start to, once patients have a response, start to give the therapeutic at a little bit of a more prolonged dosing schedule, and hopefully that actually makes the T cells healthier over time and decreases their risk for toxicity, including infection. And we haven't had any problems with relapses per se when doing it in patients in response. So this is, I think, the future, is to try to find out really what the best schedule is after people have achieved a response.
Right. Mary V?
Yeah, no, I think that this is extremely important because the label is weekly for at least 6 months, and maybe if the patient is able to achieve a good response before, it is possible to move to different dose schedule, as Tom said. And this is going to be able to maintain the efficacy. I think this message is important for the patients and will improve the safety profile, especially the infections rate, as well as maybe even the need for IV immunoglobulins. And I think that this is the way in which we have to move forward, together with maybe fixed duration. Now all clinical studies plan bispecific monoclonal antibodies until progressive disease. But I think that it is the right moment also to plan some studies planning fixed duration of therapy. This will allow to plan optimal sequencing of therapy with other immunotherapeutic approaches, and definitely this will be in favor of a safety profile.
Yes, absolutely. All good points, yes. Now, this is just kind of a final comment here, really. So the venetoclax Canova trial, some updates with some observations in different risk groups. And as you would expect, we're continuing to see benefit in the 11-14, BCL2 high, and 1Q plus. The question really is, how do we see this moving forward? Clearly, there's thought about an additional BCL2 targeted agent. It does seem that despite all of the issues that we had with the large randomized study with the Bellini, that there is still significant promise with the BCL2 targeting, you know? María-V, what do you think?
Yes, so the Canova study overall, patients have to know that it was a positive trial because we observed the benefit for patients with 11-14 translocation when they receive venetoclax dexamethasone in comparison with pomalidomide and dexamethasone. But well, the trial didn't meet the primary endpoint, and this was the reason why venetoclax and dexamethasone will never be approved for 11-14 translocation myeloma patients. But this doesn't mean that venetoclax is not an effective agent for this population. And what we've seen in this study, in this sub-analysis, was that when we incorporate overexpression of BCL2, it's true that the proportion of patients in which venetoclax can be effective increased from approximately 20% of the patients in which it is possible to see only 11-14 translocation to up to 50% of the patients that can present also overexpression of BCL2. So I think that this presentation, I would say that will expand the population in which we can see a significant benefit with the use of venetoclax. And I consider that the investigation and the clinical research approaches is with this type of agents is ongoing. You know that there is another BCL2 inhibitor, sonrotoclax, also with positive data for patients with 11-14 translocation. And even AbbVie is planning another new clinical study, also combining venetoclax with another molecule specific for the inhibition of BCL2. So I think that this is something positive for the patients, because I think that 11-14 translocation is the most frequent cytogenetic abnormality in newly diagnosed myeloma patients. We know that myeloma is quite complex, and it's true that 11-14 is not the only driver of the pathogenesis of the disease, but we can complement the different standard of care with this type of agents. And the most important message from my point of view is the clinical research does continue ongoing. And if the patients do receive the possibility for receiving venetoclax-based combination, if they present 11-14 translocation, I think that this is a good situation, and this is something the patients can receive as a positive thing, because venetoclax works in this population.
Yeah, and it is available, but also for the future. Maybe in a future meeting we can say that anti-BCL2 is back. We'll hope for that. Tom, what do you think?
I don't have much more to say other than, we do have to get the studies right. I'm glad there's next generation BCL2 inhibitors, because they certainly have a role, especially treating 11-14 translocated multiple myeloma. We'll get there at some point in time. Thankfully, we can actually have access to BCL2 inhibition, compassionate use, et cetera, so that our patients, if they really need it, we can get access to it at the current time, because we know it works in these patients.
Right. Okay, thank you so much. All right, so I think that we're close to the witching hour for our session today, but I'm wondering, were there any other key takeaways that you guys noted at ASCO, at EHA, or in these recent meetings and discussions? We haven't talked about all of the new agents. For example, I didn't discuss the cell mods. I don't know if you have any ongoing thoughts, any other immune therapies, different testing or biology. Any thoughts about some of the treatments that I haven't touched on so far, María-V, that we should be aware of or paying attention to?
Well, I think that we have to consider that the next unmet need that we are going to have in myeloma is the patients already exposed to PI, IMiDs, anti-CD38, and the BCMA and GPRC5D targeted therapy. So we have to consider new possibilities, new agents. You alluded to the new cell mods, and I think that they represent optimal options in order to plan adequate sequencing. I usually say that we have to try our myeloma patients. They have to receive not only just one BCMA targeted therapy, one GPRC5D targeted therapy. If needed, the patients have to receive subsequent immunotherapies. And in order to learn how to sequencing, we have to incorporate maybe in between the new cell modes that they are going to restore and to enhance the immune system. And I think that the data we are having from both mezigdomide as well as iberdomide are quite encouraging. And there are different phase 3 clinical trials ongoing that I consider that finally we will have both iberdomide and mezigdomide in our clinical practice. And we see in these ASCO and EHA congresses how all these novel immunotherapy approaches are moving to earlier lines of therapy. And we had the opportunity to see some CAR-Ts even in the first line of therapy as consolidation after autologous stem cell transplantation. So this means that we are also closer to reach the cure of patients with multiple myeloma. From my point of view, we have all ingredients. If we select standard risk patients, we select the most appropriate therapies, the optimal ones, and we utilize the optimal techniques for the evaluation of the disease response, MRD negative sustained over time. Why not we have to be optimistic, potentially curing patients with multiple myeloma? These are my thoughts.
Yes. So I agree with this last point. Maybe just to give a little more detail on that. I mean, I think that we are trying to push towards curing at least a subset of patients who might achieve sustained MRD negative at 10 to the minus 6 or even greater. And we do have significant or increasing numbers of patients with coming from several trials who meet these criteria, and a number of these patients are reaching the point where they have been in remission and MRD negative for 5 years, moving out towards 10 years. So part of this is about how are we going to define a cure, functional cure or MRD negative cure. When can we start to say that maybe a patient can be considered to be cured, or should we not use that word yet?
Maybe we, well, I think that this is something hard for us as physicians, because we don't want to create overestimation to the patients, but patients have to know that we are fighting in order to reach the cure, and I think that this is something that we will reach.
Right.
Tom? I think the new definition per se is the sustained MRD negativity for 5 years, and maybe in that regard, patients will live a normal lifespan, and it'll be natural causes that people die from, and not from myeloma, which would be great. I will add, on terms of the novel immune therapies, we also did hear about Cevostamab, which targets FcRH5, and very high response rates, 67% in patients that had received prior BCMA targeted therapy. So we are excited to try to get that therapeutic across the finish line so that we can use patients who have relapsed and refractory myeloma, especially after BCMA targeted therapy. But I also think it can be part of the solution to the cure.
Yes, to really push in that direction. Yeah, so I agree with all of these thoughts. But definitely the positive thing is that we are talking about heading towards achieving cure and how to define it. But along the way, patients are really having longer and longer remissions, whether they be MRD negative or even with a tiny amount of residual disease. So I think that with this, we have reached the end of our allotted time. And so I hope that our discussion has been helpful for our audience today. We've covered a lot of new things, a lot of exciting discussions actually at these recent ASCO and EHA meetings. And so thank you so much to Dr. María-Victoria Mateos from Salamanca in Spain, and Dr. Tom Morton, also currently from somewhere in Spain, who is joining us today.
Granada.
All right.
In Granada? Wow.
Okay. Okay, well, enjoy, and we will see you when you're back here at UCSF sometime in the near future. But thank you guys for your involvement and words of wisdom today. And so, thank you so much.